Uh, Excellent. So now that recording is in progress, hello everyone. And it gives me great pleasure to stand in place of President Mohit Shah, who's unable to join us, to greet you on this pre-Christmas celebration of the Young Guns. You know, the Young Guns has been our greatest hit in recent times in terms of bringing to all our attendees exactly what they have wanted for a long time. And that is people with fresh minds presenting what we should be learning with a fresh mind, unlearning and relearning. And my special thanks to Dr. Alok Varshni for putting this concept through, for getting people together. And this evening, excuse me, that's Delhi's Pollution Network. And this evening, for inspiring Dr. Naveen Pereira to get together 6 great guns. They are not great just because they're ladies. They're great because they're going to present great work. I was looking at some of the slides that they were showing us, and I really look forward to an excellent evening. My congratulations for each of them for putting this great thing together. And what I would also like is for you to give us a feedback towards the end of the program on whether this is catching up with your standards, meeting up with your standards, and how you would like us to steer this in the future. And I'm sure that we will put together this for all the other states where we haven't had one so far. And all you have to do is to be in touch with the Central Office of Society of Fetal Medicine, copy that email to Alok Vashne, and our regional coordinators will look after you. So I truly look forward now to this great mixed bag from the young guns of the entire Ludhiana and the adjacent Punjab region. So over to Naveen Pereira to introduce the team for today.
Good evening, sir, and good evening to all who have tuned in right now. So, we have this excellent team of all women brigade or all girls brigade, as we would want to call it. That's Women Empowerment from Punjab. And I would hand over the reins to Dr. Maneet Kaur to basically start and introduce our presenters.
Good evening, everyone. It's my pleasure to introduce young dynamic women for today's webinar from the region of Punjab. They'll be presenting, they have a good mixed variety of cases that we'll be seeing. First is Dr. Ashima Mittal. Dr. Ashima, can you share your screen?
Yes, ma'am. I'll share.
Dr. Ashima is MD Radio Diagnosis. She has done her fellowship in fetal medicine from Adi, Bangalore, and presently she's practicing as a fetal and women's imaging specialist at Patiala Diagnosis and Fetal Scan Center. And it's always a delight to see her cases on Instagram and Facebook. Very well worked up cases. Go ahead, Dr. Ashima.
Is my screen visible in full screen?
Yes, you are.
Okay, sir. So I'll thank you so much, ma'am, for a kind introduction. Good evening to all respected seniors and colleagues. At the outset, I would like to thank SFM team for giving me this opportunity. So the title of my talk is When One Finding is Not Enough, which I'll try to demonstrate through a case at a 21-week anomaly scan that initially revealed just one abnormality, but that single finding turned out to be the first clue to a much broader diagnosis. And also how moving from isolated findings to pattern recognition led to the antenatal diagnosis of VACTERL association. So I'll show you this image. When I started scanning this fetus at 21 weeks, this was the first image that I got. So can you spot any abnormality in this? As you all can see, stomach bubble is not seen in this image. So what would you do next if you see this? Because it immediately raises this question, is it a transient finding or a pathology? So you would like to look at it again after some time. So this is a 26-year-old primary gravida at 21 weeks with no significant maternal history and no known risk factors and a normal first trimester screen. So the second clip that I'm showing, this is taken after half an hour. This is the first image we saw, and the second clip is taken half an hour. Again, we are seeing the same, that stomach bubble is not seen. Let me show you another clip. So this clip is taken after 2 hours on the first day of my scan. So again, stomach bubble was not at all visualized. As you can see here, this is heart, this is abdominal circumference section. Both adrenals are seen. However, there is no stomach bubble. We can see the portal sinus. So in order to confirm my findings, I repeated the scan the next day, and both these clips are of the second day, taken 2 hours apart. So as you can see, there's no sign of stomach bubble. It is not at all seen. So there is an absence of stomach bubble. So once you see that stomach bubble is absent, you try to look for an esophageal pouch in the neck. But instead of finding a pouch, I noticed that hypopharynx was persistently distended with fluid. As you can see here, down here, this is vocal cord and above is uvula. So both the clips are taken on the second day of my scan, uh, 2 hours apart. So I could see a fluid distended hypopharynx with somewhat convex walls. Though it was not a very convincing or obvious finding, but it still could be kept as an ancillary finding in the scan. Also, an esophageal pouch won't be easily seen at 21 weeks. It may only appear later on in pregnancy as the fetus swallows more. So, we have an absent stomach bubble, and also there was no evidence of polyhydramnios. Laika was within normal range. We have an absent stomach bubble along with the distended hypopharynx. So what would you think? It may suggest possibility of esophageal atresia with or without fistula. So once absent stomach bubble is confirmed, you deliberately search other systems for associated abnormalities. So we moved on to evaluate the rest of the fetus, which showed a normal head circumference, a normal transcerebral diameter, normal facial profile, nose, lips. Both the ears appeared normal. The long bones were within normal. All the long bones showed a length within normal range. Fetal growth was appropriate for gestational age. So what next? What about fetal spine? So this is a clip of fetal spine in sagittal section. Uh, do you see any abnormality in this? Well, it looks pretty normal to me. It shows a normal spinal curvature with a normal sacral tapering and uptilt and a normal skin covering. So the sagittal section looks perfectly fine. However, the spinal exam is not complete without a corner section. So on getting a corner section, this is this is the section that I saw. So do you spot any abnormality in this corner section? Let me show you another clip of the cornal spine. Well, I could see that, as we all can see, that there is a abnormal lateral curvature in the lower thoracic level, suggesting mild scoliosis. So these are the still images of the spine in cornal section. As we all can see, there is a mild scoliotic deformity at the lower thoracic level. Above this is cervical, lower down is lumbar section, and a lower thoracic spine shows a mild scoliotic deformity. So after observing scoliosis, what would you like to do next? You would like to have a more closer, careful look at the corner sections to find the underlying abnormality. So on closer inspection of the spine, I could see that there is a, as you can see here, there's a small wedge-shaped triangular bony structure seen at this level. This is, as you can see here. I'll show you another image here. This is a 3D MPR image. You can see a small wedge-shaped bony structure, which looks like a hemivertebra at D11 level. So counting from below, this is 12th rib, 11th rib, and this is D11 lateral hemivertebra, which is causing scoliosis at this level. So we have an absent stomach bubble, a vertebral anomaly, and it is no longer appears to be incidental. So what next? Still, there is more to the story. Sequential segmental analysis of fetal heart in this case showed a normal four-chamber view, as we can see. However, this three-vessel trachea view showed that LVOT is bifurcating into two arches, a bigger right one and a smaller left one, along with left ductus arteriosus, which are encircling the trachea. These are encircling the trachea to form a vascular ring. I'll show you another clip. So in this clip also, we can clearly see a vascular ring formed by the double aortic arch. Another color clip in which we can see a complete vascular ring in this vessel section of the heart encircling the trachea, suggesting a double aortic arch. So these are still images of the same, a double aortic arch. And finally, there was a single umbilical artery also seen in this case. While it's often considered a minor finding, but it becomes highly relevant when seen along with multi-system anomalies. So the renal evaluation in the fetus was unremarkable. We can see both kidneys with normal size and echogenicity with corticomedullary differentiation maintained, and color Doppler showing bilateral renal arteries. Also, in such kind of cases where you have an absent stomach bubble, the evaluation of perianal muscular complex becomes critical. So where you need to extend your examination. So this is an image of the perianal muscular complex in this fetus. I'll show you a clip of the same, in which we can see there's a central echogenic mucosa surrounded by a hypoechoic muscular ring, which appears to be normal PEMC, and it rules out high anorectal atresias. So at this point, we have a vertebral anomaly as hemivertebra with scoliosis, a cardiac anomaly as double aortic arch, and a probable tracheoesophageal atresia associated with a single umbilical artery. So individual anomalies mattered less than the pattern they were forming. Presence of three components was there in this case. So this constellation of findings was diagnosed as a vectoral association. As we all can see in these images, we have already discussed. So after multidisciplinary counseling regarding complexity of the case, the surgical burden it will amount to, and the long-term outcomes, guarded prognosis was explained to the couple, and the parents opted for termination of pregnancy. Abortal genetic testing was performed, which showed a normal whole exome sequencing. So an early antenatal diagnosis in this case allowed an informed, non-urgent decision-making. So moving on to a brief discussion about VACTERL, about the frequency of anomalies that one can encounter in cases of VACTERL. Vertebral anomalies in 60 to 80% cases, most common being hemivertebra with scoliosis, as we just saw, also including caudal regression, spina bifida. Anorectal atresias in 60 to 90% cases, cardiac anomalies in 50 to 80% cases, but most commonly includes VSD, ASD, and TOF. Tracheoesophageal atresia in 50-70% cases, renal anomalies in 50 to 80%, including renal agenesis, horseshoe kidneys, cystic dysplastic kidneys, genitourinary tract anomalies, etc. Limb anomalies in 40 to 55% cases, including radial ray deformities, club feet, tibial deformities, etc. So incidence of VACTERL is quite rare, 1 in 10,000 to 40,000, and etiology is unknown. It is mostly sporadic, caused by developmental defects during blastogenesis at 2 to 4 weeks of gestation, which impaired the formation of multiple organs simultaneously, and along with some environmental factors like maternal diabetes, alcohol, teratogenic drugs. So this was a study done for analysis of cardiac anomalies in VACTERL association, done by Cunningham et al. In 2013, wherein they studied 46 cases of VACTERL, out of which 31, that is 67%, had a cardiac anomaly. Most common cardiac defect being a ventricular septal defect. Severe defects included TOF, double outlet right ventricle, AVST, that is atrioventricular septal defect, aortopulmonary window, as well as a vascular ring. So majority had multiple cardiac anomalies, also including a persistent left SVC, bicuspid aortic valve, mesocardia. However, there was no statistically significant association between the congenital heart defect severity and presence or absence of other vectoral features like specifically anorectal malformation or tracheoesophageal fistula. So this is the list of cases they had studied in their case series, in which the most common cardiac defect was, as you can see here, is a VSD. Only single case had a vascular ring, as we can see in our case too. This is another case report of antenatally diagnosed VACTERL association, in which they had a truncus arteriosus with right arch and mesocardia and left atrial isomerism as a cardiac defect, along with hemivertebra, esophageal atresia, and a solitary right kidney. So the genetic defects in VACTERL are not known. It is mostly sporadic, and occasional autosomal recessive forms may be seen. It is a diagnosis of exclusion. However, when faced with this constellation of findings, several syndromes come to our mind, like Ehlers-Danlos syndrome, Ballard-Gerald syndrome, Charge syndrome, Fanconi's anemia, Fryns syndrome, Holt-Oram syndrome. However, all these have their typical features. These are genetic defects with single gene mutations. Like Ehlers-Danlos syndrome has a typical facial appearance or ophthalmic anomalies, ear anomalies. So once we encounter these vertebral finding, a vascular ring, absent stomach bubble along with a single umbilical artery, most of these differentials, they fall away, and leaving VACTERL as the most coherent explanation in this case. These were my references for today's talk, and my key take-home messages from today's talk will be that an absent stomach bubble should always prompt a syndromic search. VACTERL is a diagnosis of pattern. If you miss one system, you may miss the diagnosis. And most importantly, in fetal anomaly scanning, one anomaly should be the beginning of a system-based evaluation for other associated findings. Fetal anomaly scanning is not just about counting abnormalities, but about recognizing patterns early enough to change the counseling and outcomes. And sometimes the smallest finding is an invitation to look more deeper into the case. So thank you all for patient listening.
That was a wonderful president, Dr. Ashima.
Thank you so much.
Would you like to say anything?
It was a wonderful, seamless presentation, a good storytelling that you got throughout your presentation, and I think it ended very well with a good take-home point. Thank you so much, Dr. Ashima. Over to you, Dr. Maneet.
Yeah, it's a request to all the participants. If you have any questions, you can put them in the chat box, and they'll be discussed at the end of all presentations. So next we have Dr. Aradhana.
I'll stop sharing.
Dr. Aradhana, can you share your screen?
Yes.
Yeah. Dr. Aradhana has done her fetal medicine fellowship from Apollo Center Fetal Medicine in Delhi, and presently she is working at Apollo Hospital, Amritsar, and Dr. Bhalla's Diagnostic and Fetal Medicine Center, Amritsar. She's a regular speaker at SFM conferences, and I hope she'll be enlighten us with her case series on flat facial profile in fetuses. Over to you, Dr. Aradhana.
Yeah. Hi. Am I full screen? Yeah.
Yes, you are.
Yes.
All right. Thank you. Right. A very good evening, everyone. And I thank you for giving me this wonderful opportunity to present my work on flat facial profile in fetuses. This is a case series that I did And it was a retrospective observational study on 26 cases of flat facial profile with mid-face hypoplasia. They were all scanned between 18 to 24 weeks in the last 5 years. The ultrasound findings were consistent with a mid-face hypoplasia, a binder phenotype. Now, the anomaly scan was done between 18 to 21 weeks, and the facial abnormalities we included were nasal hypoplasia, a flat nose with an increased frontonasal angle, maxillary hypoplasia, micrognathia, a flat face, and hypertelorism. Now, we all know about the frontonasal angle, which was checked between 18 to 21 weeks, and several studies document that this is a normal value between 110 and 140 degrees, but considered binophenotype when it is above 140 degrees. And this is the increased angle, which is the key marker. Now, once that was established, we did a detailed skeletal workup of the fetus in order to check the skull, the face, the thorax, the long bones, hands and feet, and the spine in order to look for the curvature, mineralization, to look for if there were any fractures. We even targeted the scan for further looking at the soft markers to check for trisomy 21 and 18. Now, the results were as follows. Of the total 26 cases we saw, 9 of them were isolated. That means the only finding we saw was of a flat facial profile. 17 of them had associated findings, which were skeletal, with a premature calcaneal ossification or coccygeal stippling, scoliosis, hemivertebrae, hypomineralization of the spine, even short long bones. This case had a macroglossia as well. There were even cardiac findings like a small VSD, ARSA, echogenic focus, and renal anomalies were also involved, such as hydronephrosis and multicystic kidney disease. So if you look at the overall picture, a staggering proportion was actually the non-isolated cases, which was 65%. And if we look at that in more detail, most of them were skeletal abnormalities. Family history is very important here, and 4 couples had positive paternal history, but that was of intellectual disability, and none had been genetically proved. There was 1 couple with a previous child diagnosed with a binder phenotype. That's doing currently well with no neurodevelopmental delay. And 1 couple was first-degree consanguineous. 14 out of the 26 agreed to undergo amniocentesis, either with a microarray and a DNA storage or a whole exome sequencing. 1 came out positive for a Down syndrome, another a 15q11 duplication syndrome. 1 was positive for Turner syndrome associated with the SHOX gene, and 1 was identified as a variant of unknown significance. 10 of these were reported as normal. Now, just to go a little more in detail at these positive cases, the one that was Down positive actually came to us with a quadruple marker test positive for trisomy 21. On scan, the associated finding we saw was a coccygeal stippling. And on offering them amniocentesis, it came out to be positive for Down syndrome, and they discontinued. Now, the one with the 15q11 duplication syndrome was actually a twin pregnancy. This was an IVF conceived BCDA twin pregnancy in which 1 fetus had an ARSA and the other had a binder facies with an echogenic cardiac focus. Amnio was performed for both the babies and came out positive for the one with the binder facies. Now, this 15q11 duplication has been well associated with intellectual disability and neurodevelopmental disorders, which is why post-genetic consultation, the couple decided to discontinue. But before we could figure out how to discontinue this 25-weeker twin fetus, the patient had a spontaneous IUD for that 1 fetus, and they continued as a singleton till term and delivered a healthy baby with the other baby. Now, this one, which turned out to be a positive Turner syndrome with the SHOX gene involved, was actually a case that came to us with an NIPT performed somewhere else, and that was positive for the 6 chromosomes. On scan, it was indeed an isolated finding, but the amniocentesis came positive on the XP arm of the 22 number chromosome for Turner syndrome. Moreover, this was a large deletion of 55 MB, and this also involved the SHOX gene. Again, post-genetic consultation, they were informed about the guarded prognosis, and they decided to discontinue. Now, this case we actually have currently going on with us, the one with the variant of unknown significance. This is again an IVF pregnancy, and she just came to us with a binder facies on the anomaly scan. Now, we had a calcaneal ossification for this one as an associated finding. The amniocentesis for this one also revealed a mutation on the XP22 chromosome, but this time including the STS gene. But the deletion here was much smaller, about 300 kb. So this couple was advised further parental segregation because, as per the ACMG guidelines, this was classified as uncertain significance. But however, the couple were so sure they wanted to continue no matter what, they opted out of testing. This couple is at present continuing their pregnancy with us. So if we look at the overall outcome of our cases, 5 of them ended up terminating, of which 2 were genetically proved abnormal. 2 ended up having an IUD. One was the 15q11 duplication, and the other was an early onset fetal growth restriction. But a majority of them had live births. Now, all the outcomes were actually taken through case records, and whether there were any postnatal respiratory or chewing difficulties or even neurodevelopmental problems over time was inquired telephonically. All but one had no respiratory distress or surgical interventions, and 2 of our follow-ups are already 4 years old now. Now, the one that did have respiratory distress was this one fetus. This patient went all the way up to 32 weeks, but because of polyhydramnios, she went into preterm labor. Associated findings were of macroglossia, mild scoliosis, and short lung bones. This baby suffered respiratory distress at the time of birth, and the couple decided not to intervene, so there was an early neonatal demise. Now, if we look at the history behind this, it was basically in 1800s that this anomaly was actually suggested as an anterior nasal floor abnormality. Noyes, an orthodontist in the early 1900s, actually wrote a case report about it. But Von Binder, the radiologist, got to name it in the 1960s when he described the 6 distinct features of this phenotype, namely a short nose with a flat bridge, a short columella, acute nasolabial angle, perialar flatness, convex upper lip, and the tendency to a class 3 malocclusion of teeth. So how does this syndrome really happen? Well, the nasal bone is formed from the neural crest cells in the 3rd month. Because of defective medial nasal process development, there is failure of the septal cartilage to descend and project forward, and that's actually what leads to this flat nasal bridge. If we look at the etiopathogenesis of this, there are 5 major genes which are involved in the normal process of making of the nasal bone. But most of these cases are sporadic. Some are in fact autosomal recessive with a low penetrance and even reported as milder form of chondrodysplasia punctata. However, they can be part of much bigger syndromes. But by far, the most important thing for us to understand is its association with the vitamin K pathway. So basically, binder facies is a multifactorial etiopathogenesis behind it. The most important cause being idiopathic, but of course, vitamin K deficiency, which could be because of acquired causes like alcohol consumption, warfarin, coumarin derivatives, or excessive hyperemesis, or it could be inherited because of autoimmune disorders. It may even be part of syndromic etiologies, but by far, the most important thing to understand is familial trait, and that must be ruled out every time. So when we're trying to understand the embryo anatomy and the vitamin K pathway, anything which gets in the way of vitamin K or blocks it, for example, like coumarin derivatives or hyperemesis, causes undercarboxylation. And what is actually vitamin K's job? To produce coagulant factors like protein C and S, but also to form certain bone proteins, which are important for the development of the nasal bone. Now, when there is undercarboxylation, this causes poor nasal septum and maxillary growth, in turn causing the nasal hypoplasia and stippling. So when we're looking at the etiologies, anything which is mimicking a warfarin embryopathy, like SLE or autoimmune disorders, actually causes nasal hypoplasia and stippled epiphysis. Certain syndromes like Binder syndrome or chondrodysplasia punctata do the same thing. And some rarer syndromes which we are familiar with, like Cruzon or achondroplasia, may well be involved. Now, a word on chondrodysplasia punctata, simply because it's one of the main differentials of binder facies. Now, this is a heterogeneous group of congenital skeletal dysplasias, and the most classical or the common type is the X-linked recessive. It may be non-rhizomelic, rhizomelic, or micromelic. but it's all because of the deficiency of the arsenal gene. Now, this is again linked to the vitamin K pathway and ends up causing nasal hypoplasia and stippled epiphysis. So when we're working up a case of binder facies, the first thing to do is check out the profile view, measure the nasofrontal angle, establish that it's more than 140 degrees, give a full skeletal evaluation, exclude familial physiognomy, and offer them amniocentesis, especially if it's a non-isolated case. History and follow-up is so important. Not only maternal history about drugs or illness, but family history, consanguinity. This helps you decide the recurrence. And 4 weekly growth scans should be offered throughout the pregnancy to keep on checking the amniotic fluid levels and to monitor the growth of the long bones. Again, offer them amniocentesis and talk to them about the possibility of NICU support, which may be needed because of the respiratory distress if it develops. The take-home messages here are that increased nasofrontal angle is diagnostic. It's mostly sporadic, but we must consider vitamin K deficiency. It is associated with chondrodysplasia punctata and other genetic disorders. Whole exome sequencing should be considered in non-isolated cases. Isolated cases have a good prognosis. The recurrence risk is there, although it is low. So in order to conclude, binder phenotype is actually multifactorial, but if we do accurate profiling, skeletal survey, and genetics, we can give them the best outcome. But by far, the most important thing is physiognomy, and that's the normal facial appearance that we must consider and exclude before looking at whether it's normal or pathological. Because if there's a child in the family that's been down the same road before and is quite healthy now, the chances that the one that's on the way are pretty good. Thank you so much.
Great presentation, Dr. Radhana. Excellent clinical presentation. Well worked up case series, and that case with that isolated binders phenotype of trisomy 18 particularly caught my eye. That means that see we can find anything anywhere. Usually we in trisomy 18 and 13 we find so many associated clinical features, but this was particularly unique that it had this single finding that we had. Great presentation. Over to you,
Thank you,
Dr.
sir. Thank
Maneet.
you, sir.
Yeah.
Thank you, Dr. Aradhana. Your cases were really well worked up and they were and very diverse and as usual wonderful.
Thank you so much. Thank you, doctor.
Can we move on to our next presentation? It is about coarctation of aorta, a diagnosis which always puzzles us antenatally, and our diagnosis antenatally may not translate into reality. For this presentation, I'll invite Dr. Shrestha Agarwal. She's a fetal medicine consultant at Sanjeevani Fetal Medicine Clinic in Bathinda. She's been practicing there since around 10 years, and she's also running a training program in obstetric ultrasound since the last 8 years. And she has presented many cases in national as well as international conferences. Over to you, ma'am.
Thank you so much, Dr. Maneet, for such kind words. And it's such a beautiful platform. There have been two wonderful talks before me. And so I hope to live up to the expectations. The topic that I've got today is coarctation of aorta. So we'll just start off. Just to give you a brief introduction, coarctation of aorta is a narrowing of the aortic arch, very typically located in the isthmic region, that is the part of the aortic arch between the left subclavian artery and the insertion of the ductus arteriosus. It is one of the common cardiac defects, accounting for almost 5 to 8% cases of the neonatal cardiac defects. It is more common in boys as compared to the girls, with the ratio being almost 1 is 0.5. There is a high risk of recurrence of up to 2 to 6% when there is a previous child affected with coarctation of aorta, or if the mother was affected with coarctation of aorta. This has a common association with chromosomal and non-chromosomal conditions, which we'll discuss later. The coarctation of aorta can be classified into simple or complex based upon if there are any associated cardiac defects or not. Now, I present a case here that came to us for very early in the pregnancy. This was a gravida 2 para 1, and previously there was a neonatal death due to birth asphyxia most likely, though the records were not available. The NT scan was absolutely normal, but at 18 weeks, what caught my eye was the disproportion between the size of the ventricles, the left ventricle looking smaller than the right ventricle. When I switched the color Doppler on, the limb on the left was definitely smaller than the right ventricle limb. And on going to the 3 vessel and 3 vessel trachea view, I could see there is a disparity in the size between the aortic arch and that of the ductal arch, and also noticeable was the persistent left superior vena cava. The patient was asked to come back for a follow-up. Unfortunately, this video is not playing. So the summary of the findings at 21 weeks was there definitely was a disparity in the size of the two ventricles, the left ventricle being narrower than the right ventricle. The aortic root Z scores were low. It was narrow, although the ascending aorta looked normal. There was a muscular VST noted also as an associated finding. In the longitudinal section, the aortic arch appeared narrow, but there was no particular segment of the arch that I could say for sure that was showing any coarctation. In the 3 vessel trachea view, the aorta was narrow and there was a PLSVC. So the patient was advised an amniocentesis and they accepted the choice, and the results came back normal for chromosomal microarray. The patient was reassured and asked to come back for a follow-up fetal echocardiography. After 21 weeks, she came back at 32 weeks and there was a definite clear-cut shelf that was seen. That is the contraductal shelf that we see. There was a definite narrowing in the aorta. Even on the color Doppler, there was reversal of filling of the aortic arch from the descending aorta. So the summary of the findings at 32 weeks was there was a definite ventricular disproportion. The aortic root was narrow. There was a contraductal shelf and there was reversed filling of the aorta from the descending aortica. At birth, before the baby was born, this patient was advised an institutional delivery and they went ahead and did so. The baby showed the signs of distress after birth. A postnatal echo confirmed a patent ductus arteriosus and there was aortic narrowing at the level of the isthmus. However, the baby was kept for an observation. The ductus arteriosus closed after 48 hours. That it caused the pressure gradient across the isthmus to increase, resulting in evolution into coarctation of aorta. The patient was explained the prognosis. A balloon dilatation of the coarctation was done and a healthy baby was discharged on day 5 of the life. So this was the case. Now coming to the discussion of the condition. So the definition, just as I've already discussed, it is the narrowing of the aortic arch. The narrowing represents a spectrum of lesions. It can range from segmental, where it is affecting mostly only the isthmic region, to a tubular, where it can affect the whole transverse arch. Though this is less common, but this is a more severe finding and an easier to diagnose finding prenatally. Or the coarctation of aorta can also be differentiated into preductal, justaductal or postductal. For our purpose, segmental and tubular is more important. So what are the ultrasound findings that lead to the suspicion and diagnosis of a coarctation effect? Please let me tell you that it is a difficult condition to diagnose prenatally, especially when the lesions are milder. This may become evident only after the baby is born or maybe in late pregnancy. Once the baby is born and the ductus arteriosus is closed, that's when it many a times becomes visible. The first hint that you may get in ultrasound is the ventricular disproportion, as happened in my case. In the 4-chamber view, the left ventricle is narrower as compared to that of the right ventricle. This is a subjective finding. We can objectify the subjective finding by measuring the width of the ventricles just below the AV valves at the end of the diastole. When the ratio of the right ventricular width compared to the left ventricular width is more than 1.69 is the cutoff that we take. Now, and unlike a hypoplastic left heart, here the left ventricle contractility is good and the mitral valve is patent. The aortic root may appear narrow, as I had showed earlier in my findings. However, the ascending aorta is typically normal and there is forward laminar flow there. three vessel trachea view, where you can see the disparity between the great vessels, where being aortic arch being narrower than the ductal arch, is a more specific sign that we see in the ultrasound as compared to the ventricular disproportion. It is the longitudinal section of the aortic arch which is the direct diagnostic sign as compared to the indirect signs that we see in the four chamber and the three vessel trachea view, as this also gives more information about the length as well as the degree of the narrowing. The aortic arch appears narrower and sometimes it is tortuous, that is when we call it the contraductal shelf. This is a wonderful article that is on the meta-analysis that was done of more than 20 studies that involved more than 640 cases of coarctation of aorta that were suspected prenatally, and this compares the accuracy of different ratios and z-scores in predicting the coarctation of aorta. Unfortunately, even when we take all the ventricular disproportion and the different disproportion between the great vessels or the z-scores of our arches, even then the predictability is only moderate. So what are the associated anomalies that we can suspect? There can be a lot of cardiac anomalies that can worsen the prognosis. Bicuspid aortic valve being one of them. Persistent left superior vena cava, as also was seen in my case. The cases especially where you just notice a persistent left superior vena cava and a mild disproportion in the ventricular size. These cases should be followed up to watch for any developing coarctation of aorta later on. Other associated cardiac anomalies may include a VSD, aortic stenosis, and mitral stenosis. Whenever more than one left ventricular obstruction lesions are seen, this coarctation of aorta may be part of a larger syndrome, what we call as the Schwann complex or Schwann syndrome. There can also be unbalanced AVST with a small left ventricle, hypoplastic left heart syndrome, DORV, a tricuspid atresia with VSD, and congenitally corrected transposition of great arteries. In all these conditions, the coarctation of aorta may present as one of the conditions associated. The non-cardiac anomalies may include vascular and non-vascular. The vascular being the variations in the anatomy of the brachiocephalic artery or the berry aneurysm that may develop later on in the once after the baby is grown up. The non-vascular abnormalities may include the genitourinary tract, musculoskeletal, gastrointestinal tract in up to as many as 1/3 of the children born with coarctation of aorta. The chromosomal associations are very common, especially when there are cases of coarctation of aorta that are complex, means having their other associated anomalies. Turner syndrome is the commonest, but trisomy 13, 18, and 21 can also be noted. The commonest differential diagnosis, again, I would want to point out here is that this is a condition that is difficult to detect prenatally with a high false positive as well as false negative diagnostic rate, and it may not present until the few weeks after the closure of the ductus arteriosus postnatally. The commonest differential diagnoses are the hypoplastic left heart syndrome, where the left ventricle is much smaller, and no matter how hard you try in the three vessel trachea view, you cannot demonstrate the aortic arch here, and then obviously the color Doppler would help. In cases of interrupted aortic arch, there you may notice that yes, you try and there is no aorta seen here also, and in the longitudinal sections the aorta just keeps going vertically up into the neck rather than marking the curve here. The other conditions that can also be associated with the ventricular size discrepancy can be the differential diagnosis. Total anomalous pulmonary venous connections is another abnormality, but if you can demonstrate just one pulmonary vein connecting to the left atrium, that should be ruling that out. So what is the prognosis and outcome of these cases? The in utero course is uneventful. However, a serial examination is advised every 4 to 6 weeks to know that the severity of the condition is not going any further. As sometimes in initial cases you would notice the flow across the aortic arch is forward, but as the disease progresses, as it was in my case, there can be reversal of flow in the aortic arch, which makes it a duct dependent lesion and hence the baby needing immediate delivery. The delivery should be done at the tertiary care center, and a prostaglandin infusion should be started so that the ductus does not close, causing it and making it an emergency. The overall prognosis following a successful repair of a simple coarctation of aorta should be considered excellent. However, if these babies develop IUGR or there are associated anomalies, these can have a significant negative impact on the outcome. Please do know that the prenatal diagnosis improves the outcome, because in such cases you are more alert, the patients are already well aware of the possibility, and the treatment is readily available. On the as an oxymoron to this, the cases that are diagnosed prenatally are more often severe, so there can be the poorer prognosis also. But it is, as a fetal medicine specialist, it is important for us to raise the alarm in such cases. Even if it proves to be false positive, at least the postnatal echo and the sequential postnatal echoes can make the treatment available at much earlier and save the babies in such cases. To conclude, a coarctation of aorta is a difficult to diagnose condition with a high false positive as well as false negative detection rate. Whenever you find a coarctation of aorta, do look carefully for associated cardiac and extracardiac abnormalities. Amniocentesis should be offered for further prognostication. If isolated, they should be followed up every 4 to 6 weeks, and a tertiary center delivery is a must, whether there is an availability of immediate prostaglandin therapy. Thank you so much.
Thank you, Dr. Shrestha, for this excellent presentation.
Thank you, Dr. Mani, and thank you to the organizing committee for having me.
Sir, would you like to say a few words?
Yeah. Thank you, Dr. Shrestha. That was an excellent presentation by a seasoned fetal medicine specialist, and your take-home points were wonderful, that we need to always look at other systems and not take it in isolation. Thank you so much.
Thanks.
Now we'll be taking a short break from before the next 3 presentations. And can we have trade partner videos? Welcome back. Next on the list is Dr. Vidhi Hatti. She has done her fellowship in fetal medicine from Mediscan, Chennai. She's presently working at Prime Diagnostic Center, Chandigarh. And she'll be presenting a very interesting case on monochorionic twin pregnancy, highlighting that on ultrasound, sometimes things may not be as they seem. Over to you, Dr. Vidhi.
Good evening, everyone. Thank you, ma'am. And I'm Dr. Vidhi Hathi. And today I have a very interesting case which will take us to the very basics of twin ultrasound. And so without further ado, I'll start the case. So we had a 34-year-old primigravida with an IVF conception, a twin pregnancy, who came to us at 25-26 weeks of gestation for a well-being ultrasound. And as soon as we put the probe, there were 2 placentae, 1 anterior, 1 posterior, no connections in between. And it looked like a fairly straightforward dichorionic twin pregnancy. However, when we saw a little further, things were not as easy, because the membrane that we saw was actually a thin membrane, and there was no lambda sign there. The membrane actually looked like a T sign on ultrasound. The fetal genders were the same. We rechecked the placentae. The placentae were actually 1 anterior and 1 posterior. And both the twins had nice separate cord insertions, one on the anterior placenta, one on the posterior placenta. We looked nicely dichorionic as far as the placentae were concerned. So we saw the previous ultrasounds. Luckily, the patient had a previous ultrasound at 6-7 weeks at our center itself. And there, this was the image. It was a single gestational sac, 2 yolk sacs, 2 embryos, clearly a monochorionic twin pregnancy. The ultrasounds in between at 13 weeks and 20 weeks were done elsewhere. One had been reported as a dichorionic, one as a monochorionic. So was this a monochorionic pregnancy or a dichorionic pregnancy? And yes, we did check. We didn't have the wrong name of the patient or the wrong records. It was the right patient, the right scans. But the early scan looked monochorionic. The later one looked dichorionic. There were two distinct masses. So dichorionic, and an early ultrasound looked like monochorionic. There was a T sign in this scan and a thin intertwin membrane, both pointers towards a monochorionic twin pregnancy. However, both these signs do lose accuracy in the second trimester, and 7% dichorionic twins can actually have a T sign in the second trimester. And even membrane thickness only has a 75% accuracy in the second trimester. The fetal genders were the same, and the pregnancy did not have any complications of monochorionicity so far. But these two pointers did not help us in classifying the pregnancy either here or there. So since the early ultrasound is the most diagnostic of chorionicity, we decided to follow it up as a monochorionic twin with a mental note to examine the placenta at delivery. The patient delivered early at 26-27 weeks of gestation for severe PIH. And we got a call from the gynecologist that this is a dichorionic pregnancy. Why were you so concerned so long? There are two placentae, two cord insertions, no connection between the placentae. I cannot see any tissue here. Okay, so now we were in a diagnostic dilemma. 6-7 weeks, we were very sure that this was a monochorionic pregnancy. 25-26 weeks, we were less sure that this is a monochorionic pregnancy. And when we saw the placenta after delivery, this looked very much dichorionic. So we studied the placenta a little greater in detail. And when we looked closer, here is the placenta. And this is not actually the intertwin membrane that we initially thought it was, but the intertwin membrane was actually on one of the placental lobes here. And if you can see in the image, we have lifted the intertwin membrane, which was a thin, nice intertwin membrane. We did the dye injection studies as for any monochorionic placenta, and here were the findings. Two placentae, two placental lobes, that is, two separate cord insertions, both cord insertions central, twin A's arteries labeled with yellow, veins with blue, twin B's arteries labeled with red and veins with green. And here is the intertwin membrane in between. And I'm lifting the intertwin membrane here, and you can see that it was a thin and flimsy intertwin membrane. And I'm trying to separate the intertwin membrane. This was a thin membrane separating only into two leaves, unlikely to have any chorion in between. The dye injection studies further did not show any vascular connections between the two placental lobes, interestingly. So this was, well, something that had a thin monochorionic twin membrane, looked like monochorionic, but no vascular connections. Still not very sure if it is actually monochorionic. The gold standard for diagnosis of chorionicity is actually placental histology. So we sent the placenta for histology, and histology actually did confirm that the membrane was two amnions and no intervening chorion. And so we had actually had a monochorionic bilobe placenta with both central cord insertions and no vascular anastomosis. So two interesting things for in this case that we had. One, something called a monochorionic bilobed or a bipartite placenta. And the second thing, the entire dilemma around chorionicity that we had throughout the pregnancy. So the monochorionic bilobed or the bipartite placenta. Literature review shows only a handful of case reports. There are a total of 10 cases at least published in literature of the monochorionic bilobed or a bipartite placenta. But likely this is a underreported finding, and this may be present in up to 3% of monochorionic twins. That is three in every 100 cases. And since we generally consider the number of placentae as sine qua non for chorionicity, this can be a reason for why certain number of monochorionic pregnancies are misdiagnosed as DCDA twins. And the chorionicity, if the pregnancy is uncomplicated, is never actually corrected, or the chorionicity is reclassified only when these twins develop complications of monochorionicity, such as twin-twin transfusion or single fetal growth restriction. This becomes especially more important in later gestations where the classical signs of ultrasound signs of chorionicity determination become much less reliable. Now, these case reports, these are images from the case reports that have been published, and most of these case reports actually report abnormal cord insertions for either one or both of the twins, that is, velamentous or marginal or abnormal cord insertions. However, the presence of the bilobation does not preclude vascular anastomosis. The placenta can be bilobed and still have placental anastomosis running in the membranes, and thus these pregnancies are equally prone to the development of complications of chorionicity as any other monochorionic pregnancy. However, the problem arises because since the placental architecture is different and the architecture of the vascular connections is very abnormal, the prenatal interventions when complications develop become technically very challenging in these placentae. A little more detail about the two case series that were there when we reviewed the literature. One is from 2006 with 3 cases. The other one from 2000, very recent, from 2019 with 5 cases, a total of 8 cases. And in both of these case series, all the cases had at least one of the 2 fetuses with an abnormal cord insertion. Complications of monochorionicity were very prevalent in 6 of the 8 cases. Prenatal intervention was actually indicated in 7 out of these 8 cases reported, and in one because of congenital malformation for one of the twins. However, prenatal intervention could actually be performed in only 4 of the 7 cases due to technical difficulties arising out of the abnormal placental locations, the abnormal architecture of the placentae, and the abnormal locations of the vascular connections. Our case was a little discrepant in this regard that both the cord insertions were nicely centrally located and there were no vascular connections in between. So our patient actually got really lucky and throughout pregnancy behaved like a dichorionic pregnancy, which actually did start off as monochorionic, but dynamically behaved completely as a dichorionic pregnancy. There may be a reporting bias, also a significant reporting bias in literature, because cases like ours may, when picked up, when chorionicity is looked at only in the 2nd trimester, may actually be missed, may never be diagnosed as monochorionic until and unless they develop complications or we go ahead and do placental histology for all our cases. So the second interesting point in my case was the determination of chorionicity and when and how it should be done. So the ISO guidelines, just a recap, we all know this, do state that chorionicity should be determined in the early 1st trimester, that is before 13 weeks and 6 days. Before 14 weeks of pregnancy, there are 3 criterion: membrane thickness, the T sign versus the lambda sign, and the number of placental masses. In the 2nd trimester, after 14 weeks, these signs become a lot less reliable. Membrane thickness has only a 75% accuracy. Again, in the 2nd trimester, the T sign versus lambda sign, yes, is reliable, but 77% of DCDA twin pregnancies can actually have resorption of chorion by the 2nd trimester and can actually have a T sign. Fetal gender may help slightly, and the number of placental masses may add corroborative value. However, all these signs can have false positives or false negatives, and hence chorionicity, once again, should be determined always before 14 weeks of gestation. A combination of ultrasound features has much more predictive value than a single ultrasound feature alone. Any of these features of chorionicity should never, ever be used in isolation to diagnose chorionicity. And importantly, the ISO guidelines also state the same, that an ultrasound image demonstrating the chorionicity should always be kept in records for future reference. And for further reading, I would refer today's audience to this very brilliant expert review from 2018, which actually discusses all of these signs of chorionicity one by one, tells us where each sign can become a false positive or a false negative. So, to conclude, please determine chorionicity early. Please keep an image of the chorionicity always. And whenever seeing a twin gestation in the second trimester, always look back at the early images of the chorionicity. Thank you.
Excellent presentation, Dr. Vidhi. I must congratulate you for all the effort that you made to evaluate your case so methodically and meticulously. Excellent case. And obviously, excellent take home messages that we have to look at curiosity in all the trimesters, and we should go back to our early first trimester images if we have any doubts.
Yes, very interesting cases, Dr. Vidhi. Congratulations. Very well worked up case, right up to placental histology. And thanks for reinforcing and driving home the point, really, that the learning point that the best time to look for chorionicity is in the first trimester. Well done.
You.
Over to you, Dr. Maneet.
Yeah. And next we have Dr. Pooja Puri. Dr. Pooja, can you start sharing your screen?
Yes, ma'am.
Yeah. And Dr. Pooja has done her fellowship in fetal medicine from Bangalore Fetal Medicine Center. Presently, she is a fetal medicine specialist at Dr. Pooja Scan and Fetal Care Center in Kotkapura. She is also a visiting faculty at GGS Medical College, Faridkot. And she has pioneered invasive fetal procedures in Faridkot district. And she has keen interest in fetal invasives, fetal echocardiography. Over to you, Dr. Pooja. She'll be presenting on echogenic thoracic lesions, a case series.
Thank you, Dr. Maneet, for those kind words. I'll start with the fetal echogenic thoracic lesions in peripheral setting. Coming on to my first case, she is a 20-year-old priming gravida who came to us at 22 weeks of gestation for the anomaly scan. We saw a triangular echogenic lesion on left side of the thorax. Rest of the anomaly scan was normal. No pleural effusion or hydrops was seen. So this is the echogenic lesion out there. This is the axial view. On putting on the power Doppler, we saw that the lesion is getting the blood supply from the aorta. So we came to the diagnosis of bronchopulmonary sequestration intralobar as the systemic blood supply was from the aorta. Since these lesions have no genetic association, patient was advised follow-up scans and patient came to us for a 32-week scan. The lesion had completely disappeared by then. She delivered a live male baby at term and the baby is doing well at 14 months of age. Similarly, another case who came to us at 22 weeks, priming gravida for the level 2 scan. And this is the clip. You see the echogenic lesion here and the blood supply is from the descending aorta. So this is the still image of the same diagnosis of bronchopulmonary sequestration intralobar was made. So we had total 5 cases of bronchopulmonary sequestration over a 5-year period from 2021 to 25. Resolution of the lesion was seen in 4 of the cases in subsequent scans. Only 1 case was asymptomatic till 4 months. Then the baby developed recurrent episodes of respiratory infection and unilateral lobectomy was done at 7 months of age. Baby is doing well at 1.5 years. So coming on something about BPS, this is a mass of non-functioning lung tissue that does not communicate with the bronchial tree. They are generally unilateral hyperechogenic lesions seen in the lower lobe, mostly on the left side. Color Doppler feeding vessel is from the descending aorta. Mostly these cases are intralobar. 75% of these are seen as intralobar. There is no increased risk of chromosomal and genetic syndromes. And we have to scan every 4 to 6 weeks. There is generally regression or disappearance of the lesion in the 3rd trimester. A little bit about embryogenesis. This is an extra lung bud. If it arises prior to the pleura formation, it gives rise to intralobar sequestration. If it arises after pleura formation, that is an extralobar sequestration. So another differentiating feature is the drainage is via the pulmonary veins in case of intralobar BPS. Congenital anomalies are rare in case of intralobar variety of BPS, whereas in extralobar BPS, The drainage is from systemic, azygous and hemiazygous veins. Congenital anomalies like CDH and the vertebral anomalies are common in extralobar BPS. So delivery is advised at term with neonate intensive care facility. Generally, the survival rate is more than 95%. Resection of the lesion and lobectomy can be done in symptomatic babies, and there is no increased risk of recurrence. Coming on to my next case, she is a 27-year-old multigravida, came to us at 23 weeks of gestation for anomaly scan. This is a still image. So we saw an echogenic cystic lesion on the left side of the thorax with small cystic spaces. There was mediastinal shift. The heart is shifted to the right side. No pleural effusion or hydrops can be seen. Rest of the scan was normal. No other anomalies were seen. So the diagnosis of CPAM type 2 was made with CVR of 1. This is the clip. Can you see the echogenic cystic lesion? Heart shifted to the right side. So on follow-up, patient was consulted and the pregnancy was continued. She was advised regular follow-up scans every 2 weeks. Rest of the scans were done elsewhere, and on follow-up, lesion had completely regressed. Delivered at term male baby who is doing well at 2 years of age. Now have a look at this case, everyone. This is a case of bilateral echogenic lungs. Can you see the clip? This is the bilateral echogenic lungs. Heart. This is a still image of the same. So what is the diagnosis? So on putting the power Doppler, the lesion is getting the blood supply from the descending aorta on both sides. So a diagnosis of bilateral bronchopulmonary sequestration was made. This case is taken from Dr. Satyajit, and the patient had terminated the pregnancy. Coming on to my next case, she is a 26-year-old primigravida who came to us at 19 weeks of gestation for an anomaly scan. Can you see? We saw bilateral echogenic lesion on both sides of the thorax. Rest of the anomaly scan was normal. There was no pleural effusion, no hydrops, no mediastinal shift, and diaphragm was normal. So this is the axial view. This is the sagittal view. Definitely, this is the echogenic lung out there. So thought what it could be. Is it looking like chaos? No. It is not chaos. There is no pleural effusion. There is no hydrops. Diaphragm is looking okay. So is my machine setting okay? Yes, the machine setting was okay, but it was definitely looking echogenic. So I thought, let's follow this up. I gave the diagnosis of bilateral echogenic lungs, and the patient was consulted to get further follow-up scans after 3 to 4 weeks. She came to us at 24 weeks, and to my surprise, there was no echogenicity seen at all. So I thought, what could it be? And baby had delivered, and the patient delivered a male child by cesarean at term. The baby is doing well at 3 years of age. MRI done has been normal, and the postnatal X-ray has also been normal. So I learned from this that everything is not chaos. Every bilateral echogenic lungs is not chaos, and sometimes it can be a different thing also. It might be a transient bronchial obstruction by a mucus plug which went off. So next time we are going to see the echogenic lungs. Remember these lesions: CPAM, BPS, chaos, and the bronchial atresia. We'll discuss it. The next most common congenital pulmonary airway lung lesion is the CPAM. These are the most common congenital lung lesions. Mostly unilateral, right and left lungs are equally affected, mostly the lower lobes. It is due to abnormal bronchoalveolar proliferation, and they communicate with the normal tracheopulmonary tree. Blood supply is from the normal pulmonary circulation. There are something called hybrid lesions also, where there is a cystic lesion with blood supply from the aorta, what we call as a mixture of CPAM and the BPS. Stoker's classification has classified into type 0 to 4. We'll see this is the type 1 CPAM. This is the dominant cyst more than 3 centimeters. This is the type 2 when the cysts are less than 2 centimeter in diameter. Type 3 CPAM, which is a solid type of CPAM. So how we are going to prognosticate? Single best predictor of poor prognosis is high drops, which in turn depends on the volume of the whole lesion rather than the size or the type of the cyst. So how we are going to calculate? This is by CVR or the CPAM volume ratio. So how we are going to calculate? When we go to perinatology.com, there is something called CVR calculator. We measure the mass length, width and height and head circumference in centimeters and calculate the CVR. So when CVR is less than equal to 1.6, these babies have good outcome and less than 2% risk of developing high drops, and there is no dominant large cyst. Poor outcome is when the CVR is more than equal to 1.6. There is 80% risk of developing high drops. With a dominant large cyst also, there is poor outcome. So how we are going to follow up these CPAMs? Naturally careful serial antenatal observation. We have to review scans every time to look for the volume of the lesion. Evolving hydropic changes are there. If their CVR is more than 1.6, 2 to 3 times per week, CVR is less than 1.2, weekly surveillance is advised. So what if hydrops develops? If the patient is at 32 to 34 weeks, naturally give steroid coverage and deliver. Before 32 weeks, intervention is required. Medically, steroid coverage can be given, and in cases of CPAM with dominant cyst, thoracoamniotic shunting can be done. So next important cause of echogenic lungs is congenital cause is the congenital high airway obstruction syndrome, what we call it as chaos. It is an obstruction of the upper airway, that is laryngeal agenesis, subglottic stenosis, atresia, laryngeal webs and cysts, tracheal atresia, etc. Complete atresia is associated with tracheoesophageal fistula also. So this is the image of the chaos, bilateral large enlarged echogenic lungs with heart out there. This is the dilated fluid-filled airways. So remember, and point to be noted is this is the echogenic lesion which has association with genetic syndromes like the Fraser syndrome, Cry-Du-Chat syndrome, short-lip polydactyly, 22q11.2 deletion syndrome. And the next case of, we'll see the echogenic lung is the bronchial atresia. So this is, what is bronchial atresia? What causes it? It is the localized atresia or stenosis of a segmental bronchus. We see a unilateral enlarged hyperechogenic lung with mediastinal shift, eversion of diaphragm, ascites and polyhydramnios can be there. And in this, remember, there is no increased risk of chromosomal or genetic syndromes. This is an image of bronchial atresia with unilateral enlarged hyperechogenic lung. So next time, we are going to see the echogenic lungs. We are going to remember this, CPAM, BPS, chaos, bronchial atresia, and we have learned how to differentiate between them and seen how to approach a patient with echogenic lungs or echogenic thorax. So my take-home message is very important. I want to emphasize on the point is not to get scared seeing the thoracic lesions or the echogenicity on the scans. Counseling is very important to tell the patient not to abort seeing any echogenic thoracic lesion in the scan. Thank you. Thank you, Team SFM and the organizing team for giving me the opportunity. Thank you.
Thank you, Dr. Pooja, for such an engaging and lucid presentation. Your cases were very nice, especially those echogenic lungs that were transient, and that bilateral BPS case was also very nice. And wonderful presentation.
Thank you, ma'am.
Yeah, wonderful presentation, Dr. Pooja, especially driving home the point that we need to not be, afraid about any echogenic lungs. In fact, most of them, like CPAM or sequestration, also they regress with advancing gestation. And more importantly, you also told about the vascular supply is the key to differentiate between them. Thank you so much.
Thank you, sir.
So the last dynamic speaker of the day is Dr. Mehak Wadhwa. Dr. Mehak has done a fellowship in fetal medicine from Adi Center for Fetal Care, Bangalore. Right now, she is working at Dr. Mehak's Advanced Scan Center, Duraha. Can you share your screen, Dr. Mehak?
Yes.
She'll be talking about a diagnosis that often eludes us during antenatal period when the spur speaks, decoding diastematomyelia. Over to you, Dr. Mehak.
Thank you, ma'am. Is it okay? Can you see my screen?
Yes, we can, Dr.
Yes.
Meg. Please start.
Thank you. Good evening, respected seniors and my dear colleagues. Today I'll take you through how a tiny echogenic focus in the fetal spine, often overlooked, can change the story of the whole fetus. A 33-year-old primary gravida referred for level 2 scan, first trimester screening low risk, and no significant medical obstetric history. On initial survey, fetal biometry was appropriate for the gestational age, and on targeted scan of the lumbosacral spine, I could see an echogenic midline spur at the expected location of the spinal cord. On the sagittal section, this spur was seen. And on the coronal section, it showed splaying of the posterior elements at the level of the bony spur. On reviewing the axial sections, single cord was seen proximal to the level of the spur, and going caudally, I could appreciate two hemicords distal to the level of the spur. And then reviewing the sagittal section, I could see the corners seen to ends at a much lower level at L4 level, and we call it low-lying cord. And the 3D rendering confirmed the presence of the bony spur. Not to forget, the intracranial structures were unremarkable. So to summarize, bony spur at L2, L3 level with widening of the posterior elements, two hemicords distal to the level of the spur, tethering of the cord ending at the level of L4, L5, no intracranial abnormality, and lower limb movements were normal. The findings were explained to the patients, and the patient decided to go for fetal MRI. So this is the coronal section showing the bony spur in between the two strands of the hemicords. These are the axial section. This is at the level of the spur showing two hemicords. This is distal to the level of the spur showing two hemicords. And further distally, the two hemicords fuse to form a single cord. These are the sagittal sections showing the spur, bony spur. And this is another sagittal section showing the low-lying cord. This is the MRI report confirming bony diastematomyelia at L2, L3 vertebral level. So before taking this case further, I would like to discuss the fetal spine anatomy first, then its embryology, and then I'll take the diastematomyelia in detail. As we all know, the fetal spine abnormalities can be very subtle at times. So we need to be very particular while examining the fetal spine. We examine spine in three sections: axial, sagittal, and coronal section. Firstly, I'll take the axial section. This is the axial section of the vertebra showing vertebral body. This is the anterior ossification center for the vertebral body. And these two are the posterior ossification centers for the lamina. And this is the spinous process. This is the spinous process. The spinous process remains unossified during the fetal life. And this central hypoechoic structure is the spinal cord with central echogenic CSF. And these are the different levels of the axial sections of the spine. First one is at the level of the neck, means cervical spine. This is at the level of the ribs, means thoracic spine. And this is at the level of the kidneys, means lumbar spine. And a very important point, we should scan spine cranially to caudally, as caudal as possible, to include PAMC, so we do not miss the distal most very important spinal abnormalities. Now moving from axial to the sagittal section, our eyes are trained to see this section of the spine, which is the paramedian section, not the median section. At this level, we can see the two parallel echogenic ossification center. Posterior one is for the posterior ossification, posterior elements, and the anterior one is for the vertebral body. And this is the median section, the true sagittal, mid-sagittal section, where we can insonate through the spinous process, which remains unossified. So it gives a very good window for the insonation of the spinal cord. Here we can see the spinal cord with the central echogenic line, and anteriorly we can see the anterior ossification center for the vertebral body. And further, sagittally, we should see the sacral tilt. We should not forget sacral tilt. This is very important. And the last distal most vertebra that is ossified at this level period of gestation is the S4. So we can count caudally to cranially, S4, S3, and so on. So the counting of vertebra is easy with this way, rather than if we go cranially to caudally. If we go cranially to caudally, we have to start from the level of the ribs. We count from the T12 and go caudally. But this is relatively difficult, and also sometimes the number of ribs are not fixed in every patient. So this is a preferred method and relatively easier. And further in the sagittal section, this I have already said, this was the paramedian, as we could see, the two parallel echogenic ossification lines. And this is the median, where we can see the central spinal cord. This triangular structure is the conus, and this echogenic structure below the level of the conus is the filum terminale or the cauda equina. So from this, we can see the level at which the conus end by calculating from the caudal to the cranially, and in the normal fetus, it end at the level of L2. And in sagittal, we should also look for the curvature of the spine. This is a cervicothoracic curvature, and this is the lumbosacral curvature. A very important thing we should never miss to look at this hypoechoic fluid, which lies distal and posterior to the level of the conus. This is very important in diagnosing a very important entity, tethered cord. We will discuss later. And a very important point which we should be very taken care of during sagittal section, never scan the sagittal spine dry. It will increase the sensitivity to detect even a minor skin defects. Next are the coronal section. We can see these. This is the anterior ossification center of vertebral body. Further going slight posteriorly, we can see the posterior ossification centers. And here we can see thoracic rib symmetry. And in this section of the spine, we should look for the sacral tapering and the pelvic bones. This is a 3D rendering image which aids in the diagnosis of spinal abnormalities. Then I'll be taking the embryological part for the better understanding of the pathology. The three key mechanisms involved in the development of central nervous system is gastrulation, primary neurulation, and secondary neurulation. Gastrulation occurs at 3rd week, where there is formation of ectoderm, mesoderm, and endodermal layer. Then is the primary neurulation, where there is formation of the notochord, and which leads to the formation of the neural tube from the ectoderm. Then is the secondary neurulation, which helps in the formation of the distal structures, that is conus, filum terminale, and the sacrum. And as I said, this is ectoderm, this is mesoderm, this is endoderm, this is the notochord, and the mesoderm around this notochord forms somites, which helps in the formation of the vertebral column. What goes wrong in diastematomyelia? In diastematomyelia, this is endoderm, below is the ectoderm. There is formation of the abnormal ectoendodermal adhesions, which leads to formation of the accessory neuroenteric canal. Then there is mesenchymal tissue migration from the mesoderm through this canal. And notochord was supposed to form here, which gets splits because of the presence of this accessory canal, and hence two hemichords are formed. The differentiation of the mesenchymal tissue entering into the canal decides the nature of the midline septum sperm, whether it's bony, cartilaginous, or fibrous. There are two types of diastematomyelia. Type 1, duplicated dural sac, two dural sac, each containing one cord and with rigid septum. This is type 2, single dural sac with two hemichords. Reviewing our case images with central bony spur, with splaying of the posterior elements and tethered cord. What is tethered cord? It is attachment of the cord conus to the non-neuronal structures in the distal spinal canal, resulting in low-lying cord. It can be seen in both types of spina bifida, and the cause of this is thickening or fatty hilum or due to some dystrophic element, like in our case, it was bony segment. How do we identify this? The conus is seen to lie below the level of L2, L3, and the position of the CSF, that hypoechoic fluid that I talked about earlier. This is the conus lying at a lower level, and this is that hypoechoic fluid which is seen to lie anterior to the conus. What is the prognosis of diastematomyelia? It is highly variable depending on the presence of certain factors. Some give favorable prognosis, some unfavorable. The favorable prognostic factors are type 2 diastematomyelia, presence of fibrous septum, intact skin cover, isolated diastematomyelia, and normal fetus movements. And the unfavorable factors are type 1 diastematomyelia, bony or cartilaginous spur, presence of skin defect, presence of tethered cord, and associated vertebral anomalies. In our case, there was presence of bony spur and tethered cord, so it was a kind of presence of unfavorable factors. So the patient decided to terminate the pregnancy. What to counsel to the patient about this? Most babies are neurological normal at birth. The neurological deficits starts at growth spurt. So we advise long-term follow-up, and surgery is usually preventive, not curative. So the goal of surgery is to prevent further deterioration, not the reversal. So key take-home message will be in diastematomyelia, prognosis is determined by the presence of skin cover, associated anomalies, and tethering, not by the split alone. So at the end, I will say, scan completely, count carefully, and do not stop early. Thank you.
Thank you, Dr. Mehak, for your illustrated presentation, and for especially for highlighting how to examine the spine in detail in all the sections, and especially that we should have fluid behind the spine so that we do not miss out on any small defects.
Excellent
Thank you.
presentation and illustration, Dr. Mehak. Especially as Dr. Manith has pointed out, looking at the spine and the importance of the associations, especially cord tethering. That's so very important. Thank you so much.
I must congratulate everyone. The
Thank you, sir.
presentations went very seamlessly. Can we have discussion now? Can we invite
Yes.
Dr. Alok and Dr. Naveen for the discussions?
Hi,
Dr.
good
Alok,
evening.
please.
Yes, good evening, everyone. I think this went off fantastically well. This is an 11th edition of Young Guns program, and it still amazes me how our youngest of the young guns are so confident, so competent. It's simply marvelous. Kudos to all the young guns who presented today. The presentations were absolutely marvelous. And great thanks to my dear friends Naveen and Maneet and the whole team of Punjab and Ludhiana for organizing this. There are some questions, but before this, I would ask Khurana sir about his comments about the presentations today.
Thank you, Alok. It's been yet another fascinating evening. The more I believe that we can't do any better than anything, you kids and all of your team, and with you and Naveen leading this pack today, we seem to perform as great, if not better than ever before. And the young guns are becoming younger, and I'm wondering how much I will have to run to keep up. But it's a great experience, and I congratulate each one of them for putting together such excellent work and for going through it with such smooth presentations. Excellently illustrated, excellent images, and very good take-home messages. Congratulations to each one of them, and congratulations to you and Naveen for putting this together.
Thank you, sir.
So, would you believe it that Mehak and Pooja, they are the first time presenters ever?
It's very difficult to believe, but that's the way it is. I'm so impressed.
Thank you, sir. Thank you so much.
All right, Naveen, there are some questions in the chat box.
Yeah.
Let's
So
discuss.
let's start off with the first question to Dr. Ashima Mittal. The question is about genetics in VACTERL. Whether we should be recommending WS considering the cost implications. Dr. Ashima.
So yes, sir. Um, if you find these constellation of findings, like we had just saw in my case, genetic testing must be done to rule out other differentials, uh, like other genetic conditions, like Chard syndrome, Ehlers syndrome, etc. We need to rule out those genetic diagnosis first. Then, if all of them are ruled out, then we can label it as a vectoral association, as it is a diagnosis of exclusion.
Yeah,
It,
thank you. Dr. Alok, your comments,
Uh,
Dr.
the
Khurana sir.
genetic association has to be ruled out, and as Ashima has said, that it is a diagnosis of exclusion. Because similar findings will appear in many other syndromes. The commonest will be the trisomy 18. So that has to be excluded. Then other genetic syndromes have to be excluded. Now, which test to perform? I think today, Khurana sir will agree with me that whole exome sequencing is the test to go for these days. Khurana sir,
Absolutely.
your comments on this?
Yes, I completely agree with you. And there is no doubt that there are certain situations where we would think of maybe, in other situations, not in this, but here it's very straightforward that all exome sequencing is the way to go always. Uh, I think it's time for us to clarify once again that we've been misled by industry, if I may say so, on the differences between a clinical exome and a whole exome, pretending that one would be cheaper. Typically speaking, all exomes, and in fact all genetic tests, are always looked at when they get a good phenotype, and really they look for all associated things with that particular phenotype. And the industry, led by several leaders in the industry, decided that no, we will pretend that some of them are less and that we can do it few cheaper. But actually, the data that was looked at by each one of them was pretty much similar. And that, luckily, is something that we don't allow anymore to happen. What we also realize is that some of the newer exome sequencing is able to include a lot of the microduplications and microdeletions. So whenever we ask for an exome sequencing, we must ask for a deeper exome sequencing, including the duplications and deletions. And then we would be able to do a pretty good job. And that really is the test, even in this particular situation.
Thank you so much, sir. And would be decreasing the costs of exome as of now. I think we are decreasing the cost of whole exome sequencing.
It's really fairly inexpensive. The deeper one, including micro deletions and duplications, is, depending on which town you're practicing in, 12.5 to 14,000 rupees, really. And, we can bargain with them further, perhaps. There is this tendency for everyone to say that we get so many results which we don't know how to interpret, and that everything should always be a trio exome, including the meeting that Kypros Nicolaides recently had, his winter meeting in the UK. And everyone says, oh, of course, trio exome. But the fact remains that when you're trying to exclude something, you don't really need to take the parents into consideration. Anyway, we have maternal blood which is lying with us because of our maternal cell contamination evaluation. And you take maternal blood as well and keep it and don't do the actual sequencing. In fact, you don't even have to extract the DNA. You'd only do it in case you find something, and then you go right ahead, in which case then the billing can be done appropriately. But the fact remains that if you have no finding, then you don't really need the exome. It's only when you don't really need the trio exome. It's only when you have a finding and you need further interpretation, then you can go and work it up. Previously, what we were doing was sequential. You wasted 3 weeks on microarray, and then you did another 3 weeks or 4 weeks on exome. So 7 weeks were going by. Here, in 4 weeks or 3 weeks, you have an answer, and most of the times that answer is complete. So then why do you have to worry about the remaining 4 weeks? So
Yes, sir.
that's why I now suggest we do it as a single study, keep the parental samples in case of any confusion, and process them only when necessary.
Thank you so much for giving this excellent, sir, suggestion that we make. You have basically made a flow chart for us. Just look at the patient fetal sample, then if needed, we can go for the parental sampling.
Yeah.
Right, sir. Uh, the next question is by Dr. Rupa Devi Hosmani, and the question is to Dr. Aradhana Bhalla. Interesting question about the nasofrontal angle, which would be normal in the NT scan and becomes flat around 19 to 20 weeks. Dr. Aradhana, please.
Yes, that's actually absolutely right. This is something we see very often, and the reason behind this is mainly because binder phenotype in itself is actually a post-ossification disorder. By the time we get all these features collectively, for example, if you remember the phenotype I discussed initially, what are the features that make it up, which is the short nose or the perialar flatness, the short columella, or an acute nasolabial angle. By the time all of these actually come into play, we reach the mid trimester, which is why even the nasofrontal angle in all the studies that have been done has actually been reported after 18 weeks. But nevertheless, this is something that we have to understand, which is why we should be prepared to find these findings later on. In fact, even vice versa, it's been noted that if we do have this kind of a phenotype on the anomaly scan, sometimes we see this in reversal and it does sort of look like a normal angle towards the end of the pregnancy. And that's, of course, because we're allowing the fetus to grow. The maxilla even starts growing, and it can be the other way around. So, this is something progressive. You have to be aware about all these possibilities.
Thank you so much. Anyone else? Dr. Alok, sir?
Yes, so this is typical because in the first trimester, the facial skeleton is still developing, and we will not see features which are suggestive of Binder's syndrome. There was one case which I, in fact, showed in one of the talks, in which I discovered there was a septal calcification, the midline nasal septum, the cartilage got calcified, and that turned out to be Binder's facies later on. Okay, so this is something which we can look at. In my experience, if I see the face flat in the first trimester, these are more likely to be Down syndrome compared to a binder's faces. So we have to be very careful about those.
Great. Thank you so much. And the next question is by Dr. Ashish Panchal. This is to Dr. Shrestha. What is the most sensitive ultrasound marker to diagnose or suspect coarctation apart from shelf?
Okay, so Dr. Kashish, we picked the hint up in the four-chamber view for the ventricular disproportion, but I would say the most striking section is the three vessel and three vessel trachea view, where you see the disparity between the great vessels. That is where you would start suspecting and confirm it obviously by the longitudinal section to look for the shelf.
Great, thank you. Anyone?
Yeah,
Any
so
comments?
these markers, they are sensitive. Like if you say four-chamber ventricular discrepancy, if you say if it is right to left is, if you keep it 1.4, then you have a different sensitivity. If you keep it 1.6, then we have a different
Different
sensitivity.
sensitivity.
If we see the ratio between the aorta and the pulmonary artery, and the aorta is obviously smaller, then if the ratio is more than 1.4, that is roughly 75% sensitive. But all these signs, they are not very specific signs for coarctation of aorta, because we do tend to make a lot of false positive diagnoses. The only thing we can see is that if the signs are appearing before 25 weeks of gestation, then the chances of these developing into a true coarctation after birth, they are much higher compared to if we start seeing the signs in the third trimester. Because if we start seeing them in the third trimester only, then there are a lot of false positives. Roughly 14% of them, they will turn out to be true coarctation after birth.
Absolutely. And
Khurana sir, your comments on this?
Sir, what
What's
about your
experience?
views, sir?
I fully agree with this. And in fact, a lot of us are not so comfortable with measuring these things, and subjectivity is really what we like to follow. And what I've noticed is that whenever I'm convinced about something and I go back and measure the ventricles, I'm dishonest about my readings. So the first thing is to see a subjective evaluation. Then you translate that subjectivity into an objective evaluation of measurements, translate it into z-scores, and then move ahead. But really speaking, that is only when you're strongly suspecting something. Very often that shelf is so obvious that once you have the fetus in the right position, you really can't go wrong. Then, of course, there will always be that large number, significant number, well, you will miss a coarctation and which will only be picked up postnatally, and that is completely acceptable because we know that there are limitations in the evaluation of the aortic arch in a large number of fetuses, and that this is a condition that even evolves in the first 6 weeks of pregnancy neonatal life, and therefore you have to always keep that in consideration. So we'll never pick up 100% of the coarctations, and then you'll have no chamber discrepancy, nothing wrong with the lumen, and no shelf sign, and yet a florid coarctation at 6 weeks of life.
Right, sir.
Yes, sir.
Right, sir. Thank you, sir. The next question is by Dr. Ashish Sharma, and he's basically asking about the differential diagnosis for coarctation of aorta. He's talking about the third trimester, about the redundant foramen ovale. Dr. Shweshta, would you like to touch upon a few of the differentials?
Yeah, just as Dr. Alok said earlier, in the third trimester, it is more commonly physiological, the discrepancy between the ventricular size, especially where the right ventricle becomes more prominent as compared to the left ventricle. And very wonderfully pointed out that the redundant foramen ovale flap. This can lead to the disproportion between the ventricle size as well as the discrepancy between the size of the aorta and ductus arteriosus as well. So you have to watch and look at the foramen ovale, and there is again to objectify, just as Khurana sir said that it is the subjective finding, but to objectify we can look at the diameter of the foramen ovale and the ratio of this diameter to the maximum diameter of the left atrium wherever we are suspecting coarctation of aorta. So that can help us differentiate between the two.
So my opinion here is that anything that restricts inflow, the mitral inflow, is going to lead to restriction of flow within the aorta, and these vessels, they have a tendency, some of them will develop coarctation later on, okay? Because flow is required to model these vessels in the fetal life. If there's less flow is there in the aorta, it is going to, some of them, they may not develop, especially when there's an anatomical narrowing in the region of the isthmus. So anything like redundant foramen of ovale, or if we see PLSVC, which is draining into the coronary sinus, these are the things which are going to restrict the flow into the mitral valve, flow into the left ventricle. And many of these cases, they will be associated with coarctation. It's not that if we are seeing a redundant flap of foramen ovale, we can exclude coarctation. It's not like that. We have to follow these cases up, and they will require postnatal evaluation as well. We cannot be sanguine about it. Dr. Dhaval Patel has, he says in one of the comments that if there are multiple parameters with which we can look for coarctation of aorta, so we can look at the relative size of aorta versus pulmonary artery, or if the aorta is same size as that of the SVC, and the Z scores, the Z scores of the aortic arch. But in practice, all of these are not very sensitive. In fact, they are not even specific markers for coarctation of aorta. It remains a very big challenge to diagnose coarctation of aorta, sensitivity, and specifically especially in the third trimester, because that is when we start seeing all these signs. So it's very challenging.
Right. So a lot of congratulatory messages, excellent presentation, interesting case, excellent, nice presentation, great presentation. So there's a question by Dr. Amit Garg to Dr. Pooja about sequestration. Does sequestration regress or become non-detectable with advancing gestational age? Dr. Pooja, please. Dr. Pooja?
Yes, Dr. Amit, yes, sequestration does regress and becomes non-detectable with advancing gestation age. In fact, most of the BPS in our studies, and in fact, what we have seen also, because as the normal lung grows with its normal blood supply, the abnormal lung tissue, the blood supply to the abnormal lung tissue becomes less and less because the normal lung tissue is growing. And secondly, they have told that there is some decrease in the placental vascular resistance also. So the because of the decreased resistance, there is decreased blood flow through this systemic blood supply, and the blood supply to the aberrant lung tissue also becomes less. So 60 to 70% of these lesions, as in various studies, they do regress as seen with advancing gestation. And those who persist can be followed up after the baby is born.
Right. So, how would you follow up a case of sequestration, doctor? Maybe in the second trimester and third. Does it vary, or even
Yes, sir.
CPAM?
Yes, sir, it does vary. Naturally, if I am seeing a case of BPS in which the only finding is just a BPS, there is no other finding, no hydrops, no mediastinal shift, or nothing is seen. So naturally, I would be just seeing it after 3 to 4 weeks. If it is a case of CPAM, I have already told in my slides, that depends on the CPAM volume ratio. If the CPAM volume ratio is more, that has to be seen very frequently. In fact, every week also. If it is less, then it has to be seen weekly.
Right. So, any comments here, sir, Dr. Alok?
So we know that even the CPAMs and the BPS, they do regress with gestational age. In fact, CPAM, they peak somewhere around 27, 28 weeks, and then they start reducing in size. We do see some remnant or smaller size CPAMs, aberrant tissue after birth when we do a CT scan, but antenatally, there is a marked regression with gestational in the third trimester. So that is that. The pathology, why it happens, Pooja has told about the vascular supply being cut off in all these cases of BPS especially. But the exact mechanism is actually not very well known. So, but we know that 75%, 60 to 75%, they are going to regress with time. And in fact, even those with hydrops, they have also been, some of them, they can also regress with time. So CPAM is something which all these white lung lesions, we should be following these cases closely. And Dr. Dhaval Patel again asks a question at the end that how to differentiate between CPAM from hybrid lesion, and does hybrid lesion require a CVR? Pooja?
The hybrid lesion is a cystic. We see a CPAM and the BPS combined together. So this is what we see on ultrasound, is a cystic lesion with the blood supply we are seeing from the aorta. So naturally, if there is a CPAM in it, we will have to calculate the CVR.
Yeah, so sometimes it's not very easy to differentiate between the CPAM versus a BPS, especially in the first, early second trimester. If you start seeing a lesion, the vascular supply is very slender. Your Doppler settings may not be that good, and it's difficult to demonstrate the feeding vessel in the white lung mass that you are seeing. So you may end up labeling it as CPAM, and then later on you will revise your diagnosis to a BPS. But ultimately, I don't think it matters that much, because both of the lesions, they have a similar outcome. And when we have a CPAM which has cysts, big cysts, then it is a trouble. And especially even hybrid lesions, then they will behave the same way. If we are seeing macrocysts, we will have to deal with as we deal with macrocysts in CPAMs.
Yeah, and not all hybrid lesions will be cystic. They could also be solid. But typically speaking, it's correct to presume that the moment you pick up any lesion that is a hybrid lesion, then we follow it just like we would follow a CPAP. Not the benign cause of a bronchopulmonary sequestration, but the variable cause of a CPAM. So in that situation, it becomes much safer. Of course, if you're able to be lucky enough and you have really a perfectly still baby pointing anteriorly with everything, then you can pick up the drainage very well, and you're happy with that. And then you can pick up a separate supply from the lung tree versus the aorta, and that becomes possible as well. The aortic branches in a hybrid can sometimes be very, very tricky to figure out, but sometimes you're lucky and sometimes you're not. So we would never swear that any lesion is not a hybrid lesion. It could very well be one. And in that case, we just treat it as a CPAM and give them benefit of doubt.
Right, sir.
Yeah.
I have a question here, sir. In fact, two. Can we use CVR for sequestration?
Can we use, sorry?
The CVR ratio for sequestration,
Well,
like we are using
technically,
it
you
for
can
CPAM.
actually use it for any solid lesion. So
Yeah.
even if
So
we have some of these other
for
variable lesions,
prognostication, we can use it for
yes.
sequestration also.
So you could use that, but typically they don't behave as predictably as a CPAM would.
Right, sir.
Yeah. But from a prognostic point of view, it's exactly the same thing because some of these other non-CPAM, non-sequestration lesions will be really large and could misbehave a lot. Yeah.
Right, right. Thank you, sir.
And
And about the follow up, would we be following up in the same way in the second trimester and the third trimester, Dr. Pooja? Suppose we have a case that's basically regressing. Would we be following up strictly as in the third trimester, as in second trimester?
So, case of
Suppose we
CPAM.
are following weekly in the second trimester. How would be
No,
our
no.
follow up?
Generally, these lesions they tend to stabilize by 28 weeks, and then they
Right.
start regressing. So, if everything else is okay, then actually our surveillance would lessen down a little bit.
Definitely. Great, great. Thank you so
and
much.
Pooja, you had touched upon it, but what is the role of invasive testing? Would you offer invasive testing in these cases with CPAM and sequestration?
If isolated, no. If there are any associated anomalies are there, then only I would consider. Only in case of bilateral echogenic lungs, when I am considering a case of chaos, then the genetic testing is recommended.
Excellent. Right. So a lot of other messages. Excellent, excellent. And there's a question to Dr. Mehek. How to diagnose tethered cord on ultrasound antenatally by Dr. Ambrish.
There are two criterias. One is to look for the position of the conus. Normally, it ends at L2 level. And in cases of tethered cord, it ends at a much lower level, at L4 or L3 or not L4 or L5 level. And secondly, we have to look for that hypoechoic area. Normally, it is seen posterior and distal to the conus. And in cases of tethered cord, it is seen to lie anterior to the conus. So these are the two criteria that we can use to diagnose tethered cord.
Right.
So basically, in the antenatal phase, we see the conus at L3 level and the L2, L3 level. And if it is below L3 level, we have to suspect tethering of the cord. And because the tethering is because the conus is stuck to the posterior elements of the spine, so the anterior subarachnoid space is going to become, wider. So that is why we see this interior hypoechoic area in front of the conus, which normally we will see it, in a normal spine, posterior to the conus.
Right. The same light, another question, a fluid should be present normally posterior to spine. Please
Right.
explain, Dr. Mehak.
Yes, normally it should be present posterior to the spine.
Yeah.
As sir has already explained,
Yeah,
subarachnoid
absolutely.
space is
So,
posterior, right?
excellent presentation, wonderful. There's another question by Dr. Dhaval Patel. I think we already talked about it. Dr.
Yes,
Alok has already
Yes,
discussed.
yes, we have already covered these. There's one question. Isolated tethered cord, what is the significance? You had actually touched upon it in your presentation.
Yes.
Yeah.
Tethered cord, like it affects as I've already said, at birth we will not see any kind of neurological manifestation in the baby, but as the baby grows, the spinal cord and the vertebral column will grow at different levels, a different speed. Sorry, will grow at different speed. So the speed by which the spinal cord should grow upwards with respect to the vertebral column will not be as it will be in the normal fetus. So they will be stretching of the spinal nerves coming out from the conus. They will be stretching of the phylum terminale. So this will lead to the neurological manifestations in the later life. So it may affect the movements of the lower limb, bladder bowel movement. So that we will see when the baby will grow with the time.
Right. And
actually, what happens is that, many of the times when we have not made an antenatal diagnosis, and the baby is born and the child keeps growing and it starts exhibiting all these non-specific symptoms, pain, tingling, muscle wasting, clubfoot, etc. Tethered cord, unfortunately, does not figure in the differential diagnosis at times. So that is why it's important to see for these abnormalities antenatally if possible, because if we know an antenatal diagnosis, these babies, they can be followed up and they can have a early intervention, which is going to improve the prognosis so much better.
Tremendously.
Very,
Yes.
very, very important. Yes, absolutely. And there was this question about by Dr. Krish M. At what gestation age are talus and calcaneum visualized? When to call premature ossification?
Right. Should I take this one?
Yes,
Yeah.
Aradhana,
Yes.
please.
Sure.
Yeah, so basically, calcaneum ossification is expected to be around 22 to 24 weeks, and for talus, a little later. But it's not just about calling it a premature ossification. We have to understand whether it's associated with a flat facial profile, because otherwise we'll just start getting panicked about it. So, yeah, if we see all of that together, we must consider this. But even if we see it in isolation, these are babies that need to be followed up.
Right.
So there's one more question. I think Mehak, your talk has triggered a lot of anxieties. And what is the next step if we find tethered cord?
Yes. Please
Unmute
unmute
yourself,
yourself.
please.
Dr.
Mehak,
Mehak, please unmute yourself.
Per se, it doesn't have any chromosomal or syndromic association. So I think we will counsel the patient and will wait till or after the birth life, I think.
yeah, see, tethered cord is a sign. We have to look for associated abnormalities, and especially we have to see open spina bifida is easy to diagnose, but this can be a sign that we are dealing with a closed spina bifida, and some of them they cannot be diagnosed antenatally. For example, if we are having simply a dorsal dermal sinus, then it is very difficult to diagnose prenatally. The diagnosis will be made only after birth. So tethered cord is an important sign, and I think even ISOAG recommends that we should be looking at the conus, especially if we are doing a detailed study.
Yeah.
Absolutely.
And that is absolutely true. And the tethered cord is really a very dangerous disease because it remains quiet but has the same devastating effects as we have over Diastematomyelia or of any one of the lipomatous lesions within the spinal canal. And this tethering must be released as soon as possible to even prevent the onset of early hydrocephalus. So to prognosticate these, if of course you have a very obviously low cord, you already have an answer that a low cord will always be a tethered cord, and it's very natural to presume that. Then there are the cords that are tethered inside open lesions, where the cord you can actually see entering into a lipomeningocele, which will then become a lipomeningomyelocele, in which case, again, you have to prognosticate and let the parents know that it's likely to have a poor prognosis. The situation where you have just a low cord that you find, in these situations, the question is when can you demonstrate the fat into which this is truly tethered, and when will you find that? Because it's not just a fibrous tethering, there is always abnormal fat within the spinal canal as part of the pathogenesis that happens. That, unfortunately, on MRI cannot be demonstrated until about 26 to 28 weeks. We don't have any method of doing so. So there's no doubt that whenever you don't see a conus at the right step, it's really wise to do an MRI, a fetal MRI at 28 weeks to demonstrate this. And, it's not a lethal abnormality, but something that has a very poor prognosis. And with the new MTP Act, the parents would still have a choice on whether they would like to continue with the pregnancy or not. So I would suggest that whenever you find a low conus, always do a fetal MRI at 28 weeks to assess what is going on.
Thank you so much, sir,
Yeah.
for that excellent
Yeah.
suggestion.
The other new thinking, before I forget and we move on to the other situation, is this business of what we are about the evolving genetics of CPAM. So far, we used to be very comfortable and we used to say, look, there are no major genetic associations. But we do have some recent research that points to very specific gene mutations And we have the CRAS gene, the DICER1 gene, and we also have the FGFR2 genes. There have, of course, been genes that we've known always, which have these altered signaling pathways, which is our WNT, SHH type of things. But when we find that a lesion has not regressed postnatally, there is always the fear of a malignant transformation. And in those individuals, if we're able to assess them for lesions in the CRAS mutations, in case we find some of the DICER ones, then these are more prone to malignant transformation. So in CPAMs that persist beyond birth, it's wise to do genetic studies for those neonates, and then then you can accelerate a decision for surgical removal of these or not. So these are things where genetics is evolving and giving us new direction. There are some very aggressive pediatric surgeons who will remove every persistent CPAM. And we know that that is not necessary from the experience that we have gathered over the last 200 years. But there are some where we would not like to take a chance. And in those situations, it's then wise to then just assess for all these genes. And there are other genes which are coming in, the FGFs, the BMP4, SPRY2, etc., etc. And in those situations, again, we need to reconsider whether we should do a surgical removal of a residual CPAM. So it's wise to include a geneticist who's very well informed, and wise to also have a conservative surgeon who, in case there's a genetic abnormality, would then change their mind to being more aggressive and remove those lesions.
Great. That was a revelation to me too.
It's a revelation to everybody. It's something I learned only last month, and I said I must share it with everybody.
Yes.
Thank you, sir. So there was a comment about isolated coccyx calcification. Any significance, Dr. Radna? Would you like to?
So, isolated coccyx, something that we would see towards the end of the pregnancy, but again, this is pretty much benign and isolated. We don't have to worry about it. Look for a pattern, something that would link it to either a binder syndrome or chondrodysplasia punctata, stippling, associated features. We shouldn't worry too much if it's isolated.
Right. Thank you. There was a comment by Dr. Shrestha about syrinx may not be visible prenatally in tethered cord, and rightly so. And thank you, Krana sir, for nice explanation from all of us. I think that's the end of the questions. Any comments? Sir, Krana sir, Alok, anyone else?
I'm always fascinated by our young guns. We have our big guns, we have our very big guns, and we have the young guns. And it is just so gratifying to see that we're all moving together. The most fantastic thing is that India has emerged as the country where fetal medicine is practiced in the most advanced way possible anywhere in the world. The richest of nations, the ones with the largest of health outlays, are currently not doing as well as we are doing. And we can really tap ourselves on the back for having formed fabulous teams all over the country, fabulous talent all over the country, excellent support from imaging and genetics to have now come to the forefront as the country for practicing excellent fetal medicine and reaching out to the largest number of people possible in spite of our constraints. So congratulations to each one of us on the program today, and my special thanks to the young guns for always inspiring the older guns.
Thank you, sir, for inspiring and leading us forward. Comment by Dr. Ladbans. Good to know she's online. Wonderful insights. Thank you so much, sir. And thank you, Dr. Alok, everyone else.
Yeah. So Dr. Gitanjali is there, I think, online, and if she can give the closing remarks.
Yeah. Thank you, Dr. Ashok and Dr. Alok for giving us this webinar, and Dr. Naveen Pereira and Dr. Maneet for managing it so well. I'm sorry I couldn't join earlier because of an obstetric emergency. From an obstetrician point of view, all these young presenters have given us a lot of food for thought, because ultimately we are the face to the patient, and we have to explain to the patient when the patient comes with the report. So for all of us, knowing all these minute details, and then being able to counsel the patient well is very important, allaying the fears of the patient and explaining everything in a chamber. Once the patient is getting an ultrasound done, her mind is very different. When she comes and sits in front of the obstetrician, then it is at that time that discussing the options with her, and whatever with once we know these things, we are much better done to explain all this to the patient and give them the options that are available to them so that they may have a right to informed choices.
Right. Thank you so much. Thank you so much for that point of view.
Yeah, I think we can call it a night.
Yeah.
Thank you.
Nice to know so many people kept on logged in and listened to everything, and we had wonderful discussion.
Yes.
Very nice.
So a lot of insights and a lot of new revelations.
Yeah.
Most of all these cases, they trigger discussions like these, which lead to these insights and revelations. So truly a good evening.
Wonderful. And thanks, Alok, for mentoring our young guns. Thank you so much.
Presentations are very good. They've done a lot of good homework, training from basics to everything, so that everybody could follow it well.
Thanks everyone.
Thank you, everyone.
Thank you, Dr. Ashok, for keeping the flags of academics so high, the bar so high that everybody lives up to the expectations.
It's a job we do together. Thank you indeed. Yes.
And thanks, Vishal. Thanks, Conference
Thank you so much,
International team,
Vishal.
Atul.
Thanks to the SFM team at the back.
And a Merry Christmas to everyone.
The same, sir.
We are meeting tomorrow, actually. We have a next gen webinar. So I hope more all of the the presenters and the delegates, they can join us tomorrow as well.
Right.
I look forward to that as well. Thank you very much. Good night.
Good night.
Good night, everyone. Good night, everyone.